Hi everyone, we're going to be talking about chapter 17, which is toxicology. So we're going to move into our objectives for this. We're going to define a few words. We've got toxicology, poison, toxin, and overdose. And all these are going to be helpful for understanding how these drugs interact with our body. So let's look at toxicology. It's the study of poisonous substances. And I've got two definitions here for you guys besides the one that's in the book. The branch of science concerned with nature, objects, and detection of poisons, the measurement and analytics of potential toxins, including toxins, intoxicating or banned substances, and prescription of medications present in a person's body. So how are we going to use this? Toxicology report. So when you get back a toxicology report, it's going to tell you what's in that person's blood. So you take somebody to the hospital and then they do a tox report on them. They're looking to see what's inside their system. So toxicology reports will determine if alcohol was a factor in the crash. Let's say you respond to an intoxicated subject who crashed their car, and when they get to the hospital, the authority having jurisdiction, like the California Highway Patrol, will say, well, I want to get a blood tox, and then they're going to see how much alcohol is in their system or anything else that they can check for. So toxicology, the study of. We have poison, any substance whose chemical action can damage body structures or impair function. And then another definition, a substance that is capable of causing the illness or death in a living organism when introduced or absorbed. Poisons can be good in the right dose. We have multiple medications which are toxic or poisonous if you take too much of them, but they have what's called a therapeutic range. So aspirin, acetylsalicylic acid, is a drug that has a therapeutic range. We know that if someone's on 81 milligrams of aspirin a day, they reduce that ability of their platelets to aggregate. So it's an antiplatelet drug, and it prevents blood clots and strokes and heart attacks and all these good things. But if you take too much of that aspirin, you get a poison or an overdose of that medication. So depending on how much of something is taken, it can cause problems. And that is going to be with almost everything. You can drink too much water. Don't think that don't do that. Toxin, poisonous substance produced by plants, bacteria, or animals that change the normal function of cells or destroy them. And then another definition, antigenic poison or venom of a plant or animal or of animal or animal origin. I knew I can talk. Especially one produced or delivered by microorganisms and causing disease when present at low concentrations in the body. Okay, let's talk about a toxin. When we talk about toxins, I think of either animals, insects, or bacteria. And let's look at all of those things real quick. A toxin could be a bee sting. A toxin could be what's another one? Botulism. So botulism is what makes Botox. Botox is injected into the skin, and it gets rid of these fine little lines. And Botox does that because it blocks the muscle, the neuromuscular ability to contract and cause those fine lines. So Botox is botulism toxin injected wherever you need it. And they use it in skincare, obviously. You guys have all seen people that get Botox, and I'm always happy. I always have a perfect face with no lines. But they can't really smile too much because it's limiting those muscles from being able to contract. So Botox does that. They also use it in other forms of medicine as well. Like they'll treat headaches with it or chronic pains, and then they'll inject that botulism into that section that's causing that nervous response, and it's going to nullify that so that it doesn't do that any longer. So that's a form of a toxin that has a therapeutic effect, or if you have too much of it, obviously it'll be a problem. If you ingest too much of that toxin, it'll kill you. So toxins can obviously be very dangerous. All right, what makes an overdose? Overdose is a patient takes too much of a toxin or a drug or a poison, and it's either a lethal dose or a toxic dose. So they're going to have these adverse reactions or untoward actions of that medication, drug, or poison toxin. So they take too much, and now they're much worse after that. Okay, let's take a look at this. How does our body deal with toxins? And it does that by however we ingest them. And your book goes through quite a few ways. It talks about inhaling toxins. It talks about absorption through skin, through the either transdermal or through the mucous membranes. It's like putting it in your lip or in your nose. You can eat it, you can ingest it, and then obviously people can inject it into their blood. And most of the time when you inject a medication, you're going to bypass all of these other organ systems that would otherwise slow it down. So if you had a question on the EMT test that said, what is the fastest way for a drug to get into your system? It's going to be intravenous. The other option would be intraosseous or in the bone, but into the bloodstream without being bypassed or bypassing the lungs, the skin, the GI system. The slowest absorption is most likely going to be through the gut or through the skin itself. Inhaling it through the lungs is very quick. And then once it gets into your system, it's going to have to be detoxified. And our primary response for this is going to be our liver. So our liver is going to take in whatever toxin we have, and it could be alcohol, could be opiates, it could be sympathomimetics, it doesn't matter. The liver is going to initially detoxify that and then excrete the byproducts of that detoxification. And it's going to do so by either kicking it back to the lungs, into the GI system, and you poop it out, excrete it through the skin, or excrete it through the kidneys. Methamphetamine, for example, is it eventually excreted through the kidneys, so you urinate a lot of it out. And that's one way to get that out. Other medications go through the kidneys, and some do more damage to the liver and less damage to the liver. So depending on what the patient's status is, you may restrict certain medications from them. Their physician may restrict medications because they have liver damage, or they may restrict medications because they have kidney damage and they want to put extra strain on the kidneys. All of our body systems are working together to get rid of this extra junk, this poison that's in our body. Okay, so let's talk about opiates. Opiates are going to be one of our most common response calls, and it's going to be usually an overdose where somebody's having side effects from taking too much of these opiates. So opiates cause a central nervous system depression. And what that's going to look like is a patient who's going to be sleepy, incoherent, or comatose, and they're just, they're out. They're not waking up when you walk in the room. Someone called because they're altered level of consciousness, and that is what activated the 911. So anytime you see somebody who's comatose or super unaroused, and as you walk in the room, you want to check that breathing right away. So go get, sound yourself out, obviously, safety first. Hello, is there an emergency? What's going on? And then if they don't respond, you can always add in the painful response, give them a little trap pinch, or the knuckles, on the rib cage, that hurts, okay. But elicit a painful response, and then they might moan or just kind of pull away or not do anything at all. And they're very much most likely under the influence of something. It could be an opiate. So opiates also going to cause slow breathing, hypoventilation, which could lead to apnea, A meaning without breathing, apnea. Meiosis is on here. Meiosis is pinpoint pupils. And I have a bright light right in front of me. And you can see that my pupils are very much constricted. They're about 2 millimeters, it looks like. And then as I move that light away, you'll see that my pupils get bigger, and they're going to get bigger and bigger and bigger the lower amount of light that's in my face. And that's a normal reaction. So they're equal, round, and responsive to light. That'd be pearl. And then as I add light, they constrict again. Ugh. So pupillary reaction is normal. And when you find a patient who doesn't have pupillary reaction, they have pinpoint pupils, you're immediately suspecting that they have an opiate on board. Besides pinpoint pupils, slow breathing, and comatose, it also causes low blood pressure. So you can take a blood pressure and find it to be very subdued. What are some examples of these opiate medications? The most common one that you'll see as far as like a produced drug is morphine. Morphine is from the opium plant, and they take the flowers, the opium pods that grow, and they use that to create morphine. That has many subsections to it these days. We also have codeine, we have heroin, we have methadone, we have fentanyl. So we have these variations of opiates. All of them are causing these same problems. But anytime we see a patient who has that comatose, altered level of consciousness, slow breathing, we're going to check those pupils. And if we find pinpoint pupils, we're going to administer Narcan. And Narcan is in your guys' EMT scope of practice. Anytime someone's breathing is less than 12 per minute, and they have altered level of consciousness with hypoventilation, so the less than 12, altered level of consciousness, and then the pinpoint pupils, we're going to be indicated to give Narcan. Narcan is usually administered 0.4 to 2 milligrams, and usually you'll find a preloaded syringe of 2 milligrams. And for you guys, it's going to be given with a mucosal atomizer device. And that's just a little screw on the top of your Narcan administration. And it looks like a little marshmallow, kind of like a triangular marshmallow. And it sticks into the nose and has really fine holes in the top. And as you spray the medication, it sprays it in a fine mist. And it hits all the mucosa on the inside of the nose, and then it gets absorbed. Our nose is very vascular, and we absorb a lot of medication through that. So one of the ways that we administer Narcan is through the nose. And it works very, very fast. I would say that it works faster than injecting it into someone's arm. Other ways paramedics, doctors, or nurses can give this medication is intravenously, and that is faster, but you have to have an IV to do that, and you guys don't start IVs. So the MAD, mucosal atomizer device, is really the way to go with Narcan. And that is going to be an antidote to an opiate. So an antidote is going to directly undo whatever the toxin or poison is doing. So in this case, that's going to be opiates. And that opiate has an antidote, and its name is naloxone. Naloxone is got a trade name of Narcan, which is its brand name. Okay. Sympathomimetics. So a sympathomimetic is going to, I put on here uppers. These drugs mimic the sympathetic nervous system. They stimulate it. So what's the sympathetic nervous system? And when you guys are thinking about this, I want you to think about, this is going to sound funny, but I want you to think about like a thermostat in your house, like a Nest or whatever you guys have. And maybe not a Nest. A lot of people don't have Nests. Whatever. You got a thermostat. And it's got a high and it's got a low. And the high is where you want the air conditioning to come on at. So let's say we have our temperature set that if it gets over 74 degrees, the air conditioning comes on. And if it gets below 68 degrees, we want the heater to come on. So now we have a high and a low. And the thermostat is constantly trying to work one way or the other. It's either keeping it air conditioning on or heating on, or it's happy in the middle. But anytime it gets outside of that happy range or equilibrium, it's going to do something about it. So to heat up the house, we're going to use our sympathetic nervous system. And I like to think of the sympathetic nervous system as driving a car. When you guys are driving, you have your gas pedal and your brake pedal. Your gas pedal makes the car go faster. That's your sympathetic nervous system. So let's say that I am a car and I want to go faster. So I push down my gas pedal, and that's going to release epinephrine. So I have adrenaline being released from my kidneys, the top of my kidneys, from my adrenal glands, and that's going to speed up my heart. It's going to bronchodilate. It's a catecholamine, so it's going to give me beta 1, which is my heart. It's going to increase inotropy, dromotropy, chronotropy, and it's going to give me beta 2 as well, which is going to bronchodilate. So it's going to allow me to breathe faster and more air because I'm able to move more air in and out of my lungs. It's also going to cause me other things. I'm going to have pupillary dilation. My pupils are going to get bigger. I'm going to be able to see more. And that's going to happen as your fight or flight response. So anytime you see a sympathomimetic, it's going to imitate that. So let's look at some of the medications, or I'm sorry, I didn't name all the findings. High blood pressure, because you're increasing inotropy, dromotropy, and chronotropy. Tachycardia, same reason. Dilated pupils, so you can see more. And then agitation, you're fidgety, you're moving around, you're not comfortable, man. Oh, I gotta get out of here, okay? That's all sympathomimetics. And I have some examples on here: methamphetamine, epinephrine, cocaine. There's plenty of sympathomimetics out there. And some medications or some drugs will mix a sympathomimetic and an opiate. So you'll have a mixture of an upper and a downer. So you'll have a central nervous system depressant and a central nervous system stimulant. So anytime that happens, your patient has multiple things on board. We call that polypharmacy, so multiple medications, and or like poly-overdose, depending on how bad the situation it is. But treat your symptoms. And then if you see a patient who's acting like this, they have high blood pressure, they're pacing, they're tachy, they have dilated pupils, you're imagining that they're on a sympathomimetic. And when you look at a list of medications, let's say you saw a test question that said, your patient has cocaine on board, what do you expect to see? Boom, hypertension, tachycardia, dilated pupils, agitation, fidgety, anything like that where you're moving around, or the other way around. They describe those symptoms and then they give you a list of medications and they'll say, your patient is hypertensive, tachycardic, dilated pupils, and has agitation. What are they taking? They'll give you 4 things that they might be taking. 3 of them won't fit. So they'll say like heroin, oxycodone, fentanyl, or methamphetamine. And you're like, okay, these 3 are pretty much the same. They're all going to cause central nervous system depression. And this one doesn't. Even if I didn't remember that this one doesn't, these 3 are all the same, so I can't choose those. So just rule those out when you have those specific questions. Okay, so sympathomimetics, the gas pedal. I want to go to the anticholinergics because they're the opposite side. Your body has a sympathetic nervous system and it has a parasympathetic nervous system. Your sympathetic nervous system is the gas pedal and your parasympathetic nervous system is the brake pedal. So the brake pedal is going to slow everything down. So we have fight or flight, right? Fight or flight is your adrenaline. And then we have feed and breed, and that is your parasympathetic nervous system. Rest and digest, all of these things. When you're running from a tiger, you don't need to be creating urine. I think you guys have heard me say that before. And that means that your kidneys aren't functioning when you have a lot of adrenaline in your system. You don't need to be pumping blood to your hands and fingers when you are running from a jaguar. You just don't need to do it. But when you're chilling in a hot tub and everybody's just relaxing, your body's going to vasodilate, your blood pressure is going to lower, your heart rate's going to lower, and all of those things are controlled by your parasympathetic nervous system. Your parasympathetic nervous system is in charge when you sleep, and your sympathetic nervous system is in charge when you're awake. And it's like adjusting your thermometer just a little bit. When you're sleeping, it's a little bit lower. When you're awake, it's a little bit higher. Notice that when you're sleeping in bed, you may feel less tolerant of the temperature. So you want like another blanket or something like that. And that's because you have more of that vasodilation going on. So you're losing more body heat. You're not producing as much either. During the daytime, you may be able to tolerate colder temperatures, and that's because you're producing more heat. You're moving around, and through that motion, you're just able to maintain. So anticholinergics are really, really interesting because what they're doing is they're limiting the parasympathetic nervous system's response. So we have the sympathetic nervous system, and if I gave you a sympathomimetic mimicking the sympathetic nervous system, it's going to do what the sympathetic nervous system does. So let's say I gave you albuterol. So I gave you a metered dose inhaler, and you inhale that albuterol. Albuterol is a beta-2 agonist, so it's a catecholamine as well. It's going to bronchodilate. It's also going to increase your heart rate a little bit. It's going to increase your blood pressure, and it's going to make you feel a little bit agitated. If I give you epinephrine, the same thing. So let's say you got stung by a bee, you have anaphylaxis, and I give you epinephrine in your arm. You guys use your auto injector in the thigh. That's going to do the same thing. It's going to give those sympathetic nervous systems responses. Another way to counteract too much parasympathetic nervous system is to use an anticholinergic. So when we give medications that are sympathomimetics, we're mimicking the sympathetic nervous system. When we have a parasympathetic medication, that's going to slow the body down. Then we could have anticholinergics, which is instead of adding to the brake pedal, it's taking your foot off the brake pedal. Go with me on this one. All right, so you guys see down here it has tachycardia, hypertension, dry mucous membranes, and dilated pupils. those look very similar to the sympathetic nervous system. I'm going to flip back to it. Hypertension, tachycardia, dilated pupils, agitation. That's a sympathomimetic. And we have anticholinergics, tachycardia, hypertension, dry mucous membranes, and dilated pupils. All of those are very similar. In fact, they're almost duplicated. But one of them is applying the gas pedal, and then the other one is taking your foot off the brake pedal. There's two systems, the sympathetic nervous system and the parasympathetic nervous system. So imagine you're a pharmacist, and you're trying to, or you're a doctor and you're trying to deal with a patient's problem. You can do that by either affecting the sympathetic nervous system, by increasing it, giving it more gas, or decreasing it by giving it less gas, or you can increase the parasympathetic nervous system by increasing the brake pedal, or decrease the parasympathetic nervous system by removing the brake pedal. Two different systems, but you're getting the action that you want. So an anticholinergic is a drug that interferes with normal function of acetylcholine. They limit the body's parasympathetic nervous system. Okay, cool. Tachycardia, hypertension, dry mucous membranes, and dilated pupils. Examples are atropine, Benadryl, and Jimson weed. Atropine is actually one of your medications. It's only one of your medications for a very specific cause, but in like a nerve agent poisoning, EMTs can use atropine. And they use atropine mixed with Tupan. They're called Mark 1 auto injector kits, and they're specifically for nerve agent poisoning. This is like military stuff and below. And we'll talk about that. I'll talk about the below because it's very unlikely that you guys will ever deal with any sort of military version of this or weaponized version of this. But it is possible that you'll come in contact with a patient who has dealt with an organophosphate. And that's what a nerve agent is. So anticholinergics are going to cause uppers, just like sympathomimetics. But they're working on a different system. Sympathetic, parasympathetic, gas pedal, brake pedal. Apply them both at the same time and you're not moving. So you got to have a mixture of both to get what you want. Anticholinergics go against the parasympathetics. They remove the brake pedal. Sounds about right. Okay, let's talk about sedative hypnotics. Sedative hypnotics are what they sound. They're going to sedate you and they're going to hypnotize. When I say hypnotize, you're going to forget what's happening to you in that moment. This is called an amnesic effect. So it causes amnesia. They cause sedation, loss of memory, hypoventilation, and slurred speech. So when you have a patient who's taken a sedative hypnotic, they're going to be like, sometimes they have a slurred speech where it's so bad you think that they're having like a stroke. I just can't talk right now. They have poor muscle control, but it's global. It's not on one side. When you have a stroke, you have a patient who is one side affected. So I can't move my left side, and I'm like, very strokey. But with the sedative hypnotics, it's global. So the whole body's affected. And I just can't stay awake, and I'm really tired. That's a sedative hypnotic. Some examples here: diazepam, midazolam, secobarbital, and then soma. And there's a couple different medications in here. The first two are benzodiazepines. Benzodiazepines are really good for seizures. So patients that have seizures will commonly have prescribed benzodiazepines. Paramedics carry them on the ambulance, and physicians use them in the emergency room, as do nurses and every other healthcare provider that has them in their drug scope. The barbital is a barbiturate, and that's a sedative hypnotic as well. They're kind of out of fashion. A lot of patients are not prescribed barbiturates anymore, and they're very habit forming. So they have a tendency to take those medications when they're not supposed to, or abuse those medications, and it's because they're addictive. And then we have soma, and soma is a muscle relaxer. Patients that take muscle relaxers are usually going to be taking those as part of like a seizure treatment. And it's not a primary drug for seizure treatment. It's more of like a cascading one. You're still having seizures after this med. You're still having seizures after this med. Okay, let's add a muscle relaxer. And patients that have chronic back spasms, things like that, also take muscle relaxers. They're really good for that. They're very addictive, just like the benzodiazepines and the barbiturates. Very, very addictive, and people abuse those drugs. They're sold on the black market, and people will take those medications for whatever they want to enjoy the sedative hypnotic factor. Other drugs that are in this category, Rohypnol is the date rape drug, and that's a sedative hypnotic with a very powerful amnesic effect. So it's used to control a person for that action. And obviously, you know, that's something that we all need to be very, very careful of. These drugs are very powerful. Cool. That's sedative hypnotics. We talked about anticholinergics, and now we're going to talk about the opposite of an anticholinergic, or what you would use an anticholinergic for, and that's going to be cholinergic agents. So cholinergic agents are your nerve gases. They're either a gas or a liquid. And a cholinergic agent is going to affect the acetylcholine release. It doesn't necessarily have to affect the acetylcholine release as much as it's going to affect the depot. I can draw it. Let me draw it. So if I do stop share, share screen, whiteboard, share. Okay. So let's say I have a muscle end plate, and we're going to draw my muscle end plate like this. Okay. Then I have a neuromuscular junction, and across this neuromuscular junction, I'm going to have ways to take in acetylcholine. And then this is my ion gap, and what's going to happen is I'm going to produce acetylcholine over here, which is ACH, and then I'm going to release that ACH across that ion gap. As the ACH goes across, it gets taken up into the nervous tissue or into the muscle, and then it's going to meet these receptors, and these receptors are going to bind to acetylcholine. And normally what the body does is it uses acetylcholinesterase, which is going to remove the acetylcholine, break it down, and then the acetylcholine parts are going to be re-uptaken into the nerve right here, and it's going to rebuild acetylcholine. But when you have an organophosphate, we're just going to write that as, I'm doing this with a mouse, so don't hate me. Organo, and I'm not going to spell phosphate. But when we put an organophosphate into this situation, it's going to bind to these ACH receptors, and it's going to stay on there because acetylcholinesterase is not going to work on an organophosphate, which leads us to a situation where this patient is going to get a lot worse. And when I say a lot worse, I'm going to show you what I'm talking about. Okay, so it's going to create these symptoms called sludgem: salivation, lacrimation, urination, defecation, gastromotility, emesis, and meiosis. That's what an organophosphate does. That's what a nerve agent does. That's what we're really worried about. And that's why we have that atropine in your guys' skill set, because if you come across a patient who has organophosphate poisoning, you want to be able to do something about it. And what we can do is give them atropine and 2-PAN. Okay, so symptoms of a nerve agent exposure. Oh, I just said these: salivation, lacrimation, tearing, so crying, urination, peeing, defecation, pooping, gastrointestinal pain, and that's also just causing this massive movement, this peristalsis. Like all of your small intestine, your large intestine is moving really, really fast. So everything, hyperstalsis, it's moving quickly. You're vomiting, and then you have meiosis, the pinpoint pupils. Oh, cool. That's great, Justin. What am I going to do with this sludgem? Like, why do I care? Let me show you a video. So I've got this grasshopper, and I'm just going to tell you right now that this grasshopper has a parasite inside of him. And this guy is spraying this grasshopper who has been infected with this parasite. You can see it right here coming out the back of the praying mantis. He's spraying it with an organophosphate. So he's spraying it with an insect killer, That's an organophosphate. And what that does is that binds that acetylcholine receptor, and it causes all of these contractions, and everything's out of the control of the animal. And then they ultimately die, they suffocate, and it's all because of that acetylcholine receptor site. So don't hate me, I didn't make this video, but let me go back. And I want to play it. There it goes. Okay, so we've got our grasshopper, and he's going to get sprayed with an organophosphate. And this is going to kill him really quickly. But that's not why we're here. We're here to watch the parasite that comes out of him, because it has not interacted with the organophosphate yet, but it has a porous outside. We're going to be able to see what an organophosphate does to an insect or a person, looking at basically smooth muscle. So this parasite is a worm in nature, has very porous skin, and absorbs that chemical really quickly. So we'll see how it interacts. I know this guy shot this video with like a potato, but here it comes outside the back of the praying mantis is that worm that was inside of him, that parasite. And you can see that the praying mantis' body is reacting as that parasite leaves. Now watch what happens as this worm interacts with that fluid. So you see he just started touching it over there. And now you're going to start to see the contractions that this organophosphate causes. And I think he sprays it again. So we'll see. Oh, he's definitely in it now. So he's almost got his body out, but look at the top part of that worm, or the back part of that worm. Now it's starting to move out of control. And that's because those muscular sections are all being hit with acetylcholine. And it's not stopping. It's that contraction is continuous. And even though the host, the parasite, is trying to stop it, it can't control how much acetylcholine, so it's very much out of control. So salivation, lacrimation, urination, defecation, gastromotility, emesis, and meiosis. Let's see if he sprays it one more time. So it all depends with poisons and toxins. It all depends on the dosage. So how much of whatever poison or toxin did you get? How long ago? And how much do you weigh? That is all going to help us understand how toxic that is for you as a patient. And you have all these like other comorbidities as well. If you have poor kidney function or impaired liver function, things like that. You guys saw how the organophosphate causes that contraction of that whole worm. And that's really what I was looking for right there. Oh, let's see. I made this all wrong. There we go. I'll make this bigger. Okay. And then I'm going to go next. Okay, so let's look at some of the characteristics of inhaled drugs. And once again, it's really how much you take in. So we have asphyxiants, carbon monoxide, cyanide, and hydrogen sulfide. And your book talks about being able to spot hydrogen sulfide. Hydrogen sulfide is 2 hydrogen ions and 1 sulfur ion. And it smells like rotten eggs. And you're going to smell it anytime you smell rotten eggs, you're concerned that there's hydrogen sulfide because it's a very potent poison. And it does bad things to the body. Obviously, there's worse ones. Carbon monoxide and cyanide are both in here. And those are much worse. Let's look at asphyxiants. Asphyxiant means it makes you not be able to breathe properly. So working in confined spaces, manholes, pipelines, propane, methane, used for heatings, those are going to cause you, I can't breathe. And it's your body reacting to that. It's almost like a choking agent where you don't want to take any more of that poison. Gas replaces oxygen in ambient air, reducing the FiO2. And that's just your normal atmospheric oxygen. So 21% is normal at our height or our relativity to the ocean. Possible rotten egg smell can be improved with oxygen therapy. CO2 can cause respiratory acidosis. Obviously, that makes sense. If you're not getting rid of your CO2, you're going to build up a respiratory acidosis. And if you don't breathe off that acidosis, you're going to get a metabolic acidosis. it all builds up. So supplemental oxygen is great, and then conserve, support your ABCs. Okay, let's look at carbon monoxide, because this is the one I want to talk about, CO poisoning. This is the one that we're worried about. Carbon monoxide is incomplete combustion. So anytime we have incomplete combustion, whether it's through a car, any sort of running engine is going to create carbon monoxide. Anything burning can create carbon monoxide unless it's a very, very clean burn. Like when you burn natural gas or propane, you have almost a complete burn, which is why it's safe to use for cooking applications. Running a car in a garage, as we all know, is a bad idea. And depending on how efficient the car is, like if you put your Prius in the, can you turn a Prius on? Okay, but let's say you put like your very efficient car in the garage and you're trying to build up carbon monoxide, it would take a long time. But if you put your Cadillac Escalade in the garage and it has a big V8 engine, it's going to build carbon monoxide much faster because there's more fuel being burnt, and it's not being burnt as efficiently as the Prius. So fire, motor vehicle exhaust. So when they say fire, they're talking about anything burning is going to be able to create carbon monoxide. Poorly ventilated fuel burning devices. A generator inside a garage, a generator inside of a work site is going to create carbon monoxide. An improperly functioning gas heater in the garage can create carbon monoxide, can build up. And the more carbon monoxide builds up, the more parts per million of carbon monoxide. And then the higher the dose that you could inhale and get into your system. So it binds with hemoglobin because it has a huge affinity for hemoglobin. Heme and globulin. So heme is the iron, and then globulin is the protein, and it's going to grab carbon monoxide and pull it and hold it in. And it doesn't want to let go of it because it has this huge affinity for it. It's like 200 times the affinity. And oxygen will not be able to disassociate that carbon monoxide under normal conditions. So the CO2 stays bonded to the blood. History, they've been around something. It also has in here cherry red skin and lips, and that is a classical characteristic of carbon monoxide poisoning, but it's not super fast. You're not going to go to the scene of a fire and find someone who is, there's a house fire in the background, the fire department has pulled out a patient, and they're like, here you go, we got to go back in there, take care of him. They're not going to be cherry red. It's going to take time to develop that carbon monoxide poisoning. You have to be around carbon monoxide for a significant amount of time to get that. But what you can do is use SpO2, so colorimetric SpO2, so not just the normal SpO2 sensor. All of your guys' bags at UCSB have SpO2 sensors, but they're not colorimetric. When I say colorimetric, when you use certain colors, you can find whether or not it's oxygen or something else bound to the hemoglobin. So colorimetric tells you what kind of gas is bonded to the blood. And all of your 911 ambulances are going to have colorimetric, which as you put it on, it'll tell you how much carbon monoxide's in the patient's system. And dangerous levels are anything detectable. So let's say the lower limit is set at 1% of the blood has carbon monoxide in it, and it'll give you an alarm. It might be a little bit different. It might be 5%, because you have some smokers who smoke so much and so long that they have chronic amounts of carbon monoxide in their system, and that will set off that sensor sometimes. What is it going to do? It's going to give you laboratory findings of metabolic acidosis, elevated lactate, elevated CO levels. And what are you going to do? You're going to put them on a non-rebreather. So you're going to give them a non-rebreather on high flow oxygen. And you're doing that to cause a disassociation of the carbon monoxide off of the blood. So you're changing the gradient. You're taking it from 21% and you're raising that oxygen threshold up to 100%. And what you're doing is you're forcing all of these oxygen molecules in there, so they're all beating at the carbon monoxide trying to get it off. And it's going to remove that carbon monoxide faster. And I'll show you a graph on the next page. Hydrogen cyanide or cyanide. Cyanide is another product of combustion. And anytime you burn something plastic or man-made, you're going to start creating cyanides. Cyanides, let's see, plastics, rubber production, sodium, nitroprusside, acetonitrile, peach seeds. Ugh, don't eat peach seeds. Mechanism of toxicity, central nervous system impairs oxidative phosphorylation. I can do it, yeah. By inhibiting cytochrome oxidase. Bitter burning taste, cherry red lips, cherry red and lips, metabolic acidosis, elevated lactate, elevated mixed venous oxygen saturation, 100% oxygen via non-breathing mask, and that's what you're gonna do. You know, supply them oxygen. They have antidotes for cyanide. So once you get to a hospital, they're gonna be able to treat this patient for cyanide poisoning, and they're just gonna check their levels and determine how much antidote they're gonna need. We don't carry those in the ambulance, paramedics don't. In some places they do, it's in the scope of practice, but it's unlikely just because they're so expensive and they kind of have a short shelf life. So they're really gonna be found at treatment centers. Anytime you have a patient who is around anything burning for any significant amount of time, in a car, on fire, stuck in there, and then they have to get pulled out, that's a significant involvement for either carbon monoxide or cyanide. And both of those things are going to require treatment, at least evaluation. Talk these people into going to the hospital. Somebody falls asleep and then they catch their couch on fire and then they don't wake up until half the room's on fire. Somebody falls asleep and they left a pizza in the oven and it caught the whole kitchen on fire, and then they woke up to the smoke alarms going off coughing. That's a significant exposure. Another thing I want to talk about here is the possibility of pregnancy. So if you have mom and she's pregnant and she's been around a fire, the carbon monoxide and the cyanide can both go to baby. So explain that to her and make sure she goes to the hospital even if she doesn't want to, and inform the hospital of the fire because they may redirect you to a different hospital. And then we talk about hydrogen sulfides, that rotten egg smell. Give them oxygen, transport them. So I have the carbon monoxide, how to spot the dangers. So mild symptoms, headache, nausea, vomiting. Medium, severe headache, confusion, drowsiness, fast heart rate. Extreme unconscious convulsions, cardiorespiratory failure, and death. Carbon monoxide is called the silent killer. It's a colorless, odorless gas. And it'll just make you go to sleep and you're not going to wake up, and that'll be the end of it. So carbon monoxide is very dangerous, which is why CO detectors, carbon monoxide detectors inside houses save lives. Okay, this is our oxygen dissociation graph. So what we're looking at is getting CO, carbon monoxide, off of blood. And if we're breathing atmospheric air, here's our amount of bound carbon monoxide on our blood. Let's follow this graph out to 300 minutes. We still have over 50% of our blood, which will kill us. 50% bound to CO will kill us if we don't do something about it. Bound at 300 minutes. This patient's not going to survive a significant CO poisoning unless you put them on a non-rebreather. Okay, I know this is going to blow you guys' minds, but oxygen's going to save this person's life. I know it's the only time I'm going to say it. But CO poisoning, it's huge. You've got to give them oxygen. You have to give them a non-rebreather, and you want to make sure that both of those valves on the non-rebreather, remember those little valves that cover? If you take one off, it's a partial rebreather, and if you take both of them off, it's a full rebreather. We want both of those valves on, so every time they exhale, their air goes out, inhale, and they're only sucking in what's in the bag. That's a full rebreather, or excuse me, a non-rebreather. And they're only intaking 100% oxygen. So when we add in 100% oxygen, let's follow this graph, 100% oxygen, normal baric. That means that we haven't changed the barometric pressures. This is a non-rebreather. So we take that non-rebreather, put it on their face at 100%, and at 300 minutes, we're almost down to 0. We're up here on normal air, we're still at 50%, which is death. And we get below 50% at around 60 minutes. Pretty good from 100% to an hour later, we're doing well. Okay, that's good, but are some of these people gonna make it 60 minutes? There's no treatment option, and this is called a hyperbaric chamber. A hyperbaric chamber increases the atmospheric pressure around the patient. So you go into basically a glass tube, and then they seal it off, and it's in a vacuum. But instead of a vacuum, they increase the pressure, they increase the barometric pressure. And as they do that, they can force that oxygen out of your bloodstream, or excuse me, that carbon monoxide off of your blood, and they can force oxygen onto it. So you can see that at 50 minutes, or excuse me, at 50%, we're down to like 30 minutes. And we're almost completely done at 2.5, almost 3 hours. So much faster. Now, hyperbaric chambers are not found in every hospital. They're a specialty. They're used also for diving accidents. So when you have barometric pressure from diving too deep, and you have too much pressure, you can deal with those symptoms in a hyperbaric chamber by increasing the barometric pressure with air as opposed with water. So you'll find them anywhere diving is significant. Galita Valley Cottage Hospital has hyperbaric chambers, and then Channel Islands has hyperbaric chambers as well, specifically for diving injuries. They can be used for CO poisoning, significant CO poisoning. I've had one patient who took a hose, put it into his tailpipe, and then ran it into the window and duct taped the window and got in the car, and then was going to die. Somebody saw him, called 911. The fire department broke his window. They ventilated the car with their whole mask system on, and then we transported him to the hospital. As soon as we got to our closest hospital, we kept him on our gurney. We took a nurse with us, and we went down to Galita Valley because Galita Valley had the hyperbaric chamber, and this guy had such significant CO poisoning that he wasn't going to make it under normal conditions. So we had him on continuous positive airway pressure. I don't know if we had CPAP on. Might have just been on a breather. But then we did end up taking him to a hyperbaric chamber to deal with that CO poisoning. Okay, last thing I want to talk about is activated charcoal. This is your guys' antidote, and you're going to give this to patients who have overdosed on a pill medication of some kind. So you overdose on too much Tylenol, you overdose on too much aspirin, you take too much of something, and then you call 911 or someone calls 911 for you. We can use an antidote, and our antidote here is activated charcoal. Activated charcoal is going to bind to the material that's in your stomach, but it only works if it's still in your stomach. So what's our time frame? Has to have ingested it in the last hour and has to be conscious enough to swallow. Activated charcoal is a liquid. It's a suspension, and it's charcoal mixed with sorbitol. And if you guys don't know what sorbitol is, it is an artificial sweetener that causes you to have massive diarrhea in high doses. So instead of the body absorbing the sugar like it normally would with like glucose or dextrose, it causes gastromotility, and it loses the entire GI system. So it's got activated charcoal, which is going to bind everything inside your stomach, and then it has this artificial sweetener which causes you to poop yourself. So it all gets into the stomach, it starts binding, and your stomach goes, "Whoa, what's all this sorbitol doing in here?" Boom, kicks it out. The GI system's like, nope, and it just goes noggin toboggan through your system until you poop it out. So within like 15, 30 minutes, this patient's going to have a bowel movement. So let's look at activated charcoal. I've got a little video here that I stole from YouTube. It says it absorbs up to 60% of the toxic substance. So a lot of it that was ingested can be absorbed through this activated charcoal. And then the whole goal of it is also to poop it out. Normal dosages is 25 to 50 grams. And that's grams, not milligrams. So this is a lot. When you get a tube of activated charcoal, let's say this much, that would take up my hands, is 25 grams. So if I'm my size, or most of you guys, or obviously you're smaller than me, whatever, but we would need 2 of those bottles to get 50 grams. And then with pediatrics, normally you don't go above 25. This one has 1.2 kilograms per dose, or max dose of 50 grams. A lot of places you'll see it lowered to that half dose. But it depends how much they take, and is this a good reason to give it. So let's say I overdosed on aspirin. I took a whole bottle. I went to Costco, and I bought the family pack of aspirin, and I just drank it all. Then I was like, I don't want to die. And I called 911. You guys come, and then you say, okay, how long ago did you take that medication? 15 minutes ago. Perfect. Are you able to swallow this? Yes. Okay, it's not going to taste good. It's really chalky. It's sweet, but it's like really chalky. It's not very good, but it could save your life. Are you willing to drink it? Yes. Okay, cool. Boom. Base hospital physician. I've got a 30-year-old male, took a whole bottle of aspirin 15 minutes ago, and denies anything else. I want to give him activated charcoal, 50 grams. And they're going to say, absolutely give it to him. Perfect. Cool. So we're going to interrupt that absorption going on through the GI system. And we're going to take that medication orally. And it's this, like I said, you have to shake it up so that it doesn't, it gets really goopy. So you got to shake it up. All right, precautions can cause vomiting, precautions don't use if they're vomiting, unconscious, they have a gastric perforation, or reduced peristaltic movement or bowel sounds. So if they're not moving anything through the GI system, it's probably not a good idea to give this. Contraindications: GI perforation, corrosion, corrosives, hydrocarbons, benzodiazepines, cathartics, or sorbitol. So if they're allergic to sorbitol. Corrosives. Corrosives are going to be strong acids or bases. You're not going to give this medication for a strong acid or a base. It's not going to work. Hydrocarbons. It's not going to work on hydrocarbons. Benzodiazepines. Not going to work. Plus, we have antidotes to benzodiazepines. Heavy metals. Not going to work. What does it cause? Can cause constipation, black stools, and dehydration. The constipation is secondary. It's because you pooped everything out. Black stools is from the charcoal, and then dehydration because you lost so much fluid pooping it out. Overdose. Toxicity may block GIT. Storage is at room temperature. Let's look at some things it works on. I think it's on this next page. Here's how it works. It's going to go into the stomach, and it's going to collect and bind to whatever's in the stomach. Okay, what does it work on? Acetylsalic acid, aspirin, amphetamines, antidepressants, antihistamines, aspirin. That's funny. Acetylsalic acid is aspirin. Anyways, atropine, barbiturates, benzodiazepines, digitalis, which is digoxin, propofloxacin, furosemide, NSAIDs, non-steroidal anti-inflammatories like ibuprofen, Tylenol, just tons of other things, tons and tons of things. It works on more things than it doesn't. Let's look at some of the things that it doesn't work on. Cyanide, it's an inhaled gas, right? It's not going to work. Ethanol, a liquid that is an alcohol, is not going to work on. Ethylene glycol, alcohol, not going to work. Iron, heavy metal, not going to work. Isopropanol, I didn't know it didn't work on that. Lithium, heavy metal, not going to work. Methanol, liquid alcohol, not going to work. Strong mineral acids and alkali. So anything that's an acid, a base, a metal, or an alcohol, you're not going to give activated charcoal to. But any ingested pill otherwise, you probably can. Now, how do we know whether or not we're going to give activated charcoal? Well, there's a number for that. And that number is going to be poison control. So let me stop my share. And I'm going to pull up my whiteboard. I'm going to erase this. Just clear. Clear. All. Big. Draw. Oh, I can do text. Okay. And I think I've given you guys poison control's number before, but poison control, you can call them day or night, and they're always going to answer the phone, and somebody's always going to be able to help you. They're going to give you a drop-down list, like a computer list of everything that you're going to ask this. You're going to say, are you a provider? What level is your provider? Hi, I'm an EMT. I'm with a patient. They overdosed on this. They're going to ask you a few questions. They're going to ask you, what did they take? When did they take it? How much? And then weight. And then after you give them all of that information, they're going to say, yes, this is a good patient to give activated charcoal to, or no, this is not a good patient to give activated charcoal to. Activated charcoal. Okay, you guys get the idea. So what's their number? 1-800-222-1222. And I'm going to throw in the dashes so that makes it a little bit easier to see that. They couldn't pay for that last two. They just couldn't do it. And it's very frustrating because if they could, I think it would be better. Poison control. What did they take? When? How much? And what do they weigh? 1-800-222-1222. Okay, that is toxicology. And then we'll talk about, what are we talking about next? Psychiatric. See you soon.